With this, we are ready to proceed with our first talk. Martin Luzbetak from Germany, originally from Slovakia, and he has a wide experience in molecular analysis of tumors of all subtypes and histologies and all kinds of presentations of disease in oncology. We used his tests in an extensive way previously, and we look very much forward to him to share his experience with our audience. Thank you so much, Dr. Luzbetak, for attending.
Thank you, Dr. Sass, for this opportunity to present my work here. Just shortly, for my conflicts of interest, I ran a lab for molecular pathology in Düsseldorf, Germany. I personally live in also in Vienna, Austria, where I have a private practice where I'm practicing medicine. So I'm treating patients. I'm a Master of Science in Preventive Medicine and Molecular Oncology. So how we should approach the molecular testing? I mean, most of the guidelines think we should do some predictive diagnostics in metastatic patients. Why? Because our therapeutic freedom is much broader in metastatic situations. Of course, the patients are maybe heavily pretreated, maybe heavily sick, and can't have most of the therapies. So we have a lot of options. We can give them chemotherapy, maybe some targeted therapy, maybe some newer chemo antibody conjugates, and even very advanced therapeutics like CAR T cells or tumor infiltrating lymphocytes or even oncolytic viruses or some vaccines, which I believe in the metastatic situation, we need a combination of these methods. So it would be good to know which therapy to use. So there is the place where diagnostics come into the game. And of course, our patients maybe ran out of time. Maybe they just have maybe one last shot. And when the disease progressed, it could kill them. So it would be better if the shot would be the right one, and if we would use a therapy that would work, because this would always mean if the therapy works, we have more success, the patients have a better quality of life, and maybe less side effects, because the worst side effects are of therapies that don't work. So what is the problem with metastatic disease? The tumor is maybe big, it's established, it has seen a lot of therapies before, or even maybe not, even if it's de novo diagnosed tumor, which has already metastatic spread in other organs, which means the tumor is very complex. Its microenvironment is huge and it's complex. The metastasis in the primary tumor can be different, so the heterogeneity comes into play. And also, when we have done previous rounds of therapy, there is drug resistance emerging. So it's not easy to treat metastatic patients. It's in this situation, the tumor is like adaptable enemy. It can change with every round of our therapy, and it can really adapt on what we're doing. So we better test, I guess. So overall, we have a lot of options how we can do predictive testing. We can try to identify treatment-sensitive pathways or mutations, which would predict response to the therapies. Or we could extract tumor tissue or some molecules or cells from the tumor origin and perform functional assays and functional testing. So genomic profiling, I mean, everybody is aware of this method. It's broadly used. The functional testing, it's still emerging. Okay, now I have a metastatic patient. I say, okay, we need a lot of information. We need to perform another biopsy maybe because the patient has seen previous rounds of chemo or other therapies. So we perform a biopsy, have a tumor tissue, and now we can perform a lot of omics, whole genomic, whole transcriptomic diagnostics. So now we end up with tons of data. So I mean, the future is AI based. Yeah, on a conference I heard go AI or die. So I don't want to die. I want to survive as a physician and therapist. So yeah, there are options how to run these huge data sets to AI based tools, and they should help us to identify actionable mutation or pathways. So when the patient says, yeah, but to take another biopsy is maybe not the option I would like to take, maybe we can say, okay, let's take blood. Maybe we find small DNA pieces in the blood which originate from the tumor. So the cancer cells can disintegrate and shed some fragments of DNA into the bloodstream. So the advantage is, yeah, the patient says, yeah, you take blood all the time. You can now take it from some cancer predictive testing. If you take blood for blood count or biochemistry, go ahead. It's easy. So it has a lot of pros. So it reflects the real time, the situation which is now going on in the tumor. And of course, if we take sequence of these blood samples, we can monitor the evolution. So if some mutation emerges, yeah, we can find it very fast in the blood, and we can predict, for example, resistance in the therapy, or just maybe monitor the minimal residual disease. So it's quite comfortable. You need, of course, special blood tubes. You take blood, maybe not too close to other therapies. Maybe you just let the tumor be without therapy for a week or two. You then take blood, extract the DNA, and now you end up with 5 or 10 or maybe 20 mutations. Okay, in a complex situation, maybe again, an AI tool would help you to make a better decision. In a real world, we know these tools from lung cancer treatment, where you can detect emergence of EGFR mutations and so try to guide your TKI therapy, for example. Of course, there are more indications. I mean, colon cancer, for example. Of course, you could more better monitor the minimal residual disease if you look for KRAS. Of course, when you go for KRAS and you don't have G12C, which is druggable, you end up most of the times with a mutation you can't target with the therapy outside a clinical trial, so it's better for monitoring. 3D cancer models, they are quite popular. You could think, okay, this is a very small microtumor in my cell culture, and it's better than 2D cell culture because it mimics the microenvironment. Between the tumor cells, between the clusters of tumor cells, you have a lot of other cells from the stroma, maybe fibroblast, maybe some immune cells. So you better go for a situation where the tumor is really complex and you can watch how's your drug penetrating into the tumor. Maybe you could try test some combinations. And which I really like is you can combine functional testing with some omics, with transcriptomics or genomics. So you can track genetic changes in these spheroid models. What's the downside? Side is when you want to create 3D spheroids, of course, you need a real surgical biopsy. Maybe not just a small punch biopsy or jet biopsy, just where you don't have enough tissue. Maybe it's better in, for example, metastatic liver situation, perform laparoscopic biopsy to have a good piece of tumor, so you can dissolve it and go for tumor cells, form 3D microtumor spheroids in your assay, and then perform the drug testing and functional assays. Even if you have a lot of information, maybe you just go for other omics and use the help of AI. The next tool you could use are circulating tumor cells, which are my favorite. Of course, these are rare events in the blood. The circulating tumor cells go out from the primary tumor or the metastases, go into the bloodstream, where they, of course, fight with the immune system, where they can die of this. And of course, they can go back into the tumor, back into the metastasis, back in some extra tissue like bone marrow or fat tissue, where they can, of course, be of creation of new metastases, or even just be dormant and sit there. So circulating tumor cells have this rather complicated inner life, which we don't understand in every detail, but we can find them in blood. So, and we think they are of potential, of the metastatic potential, so they can create metastases, and we can perform functional testing on them. There are many methods how to find circulating tumor cells. In my lab, we use EDTA tubes, then EpCAM positive beads for selection, and then we just need to find the cells and count them. We use real-time PCR, but you can use many other methods. Why we use PCR? Because it's very sensitive and very specific. What is good on circulating tumor cells? They are of tumor origin, so you can bring them in a short cell culture, and of course, you can do drug sensitivity testing. Drug sensitivity testing makes sense when you have options. So either you can test some guideline treatment, or even out of the box. In a metastatic situation, the therapeutic freedom maybe allows the patients to ask the therapist for off-label drugs or some advanced therapies. So I would rather test some off-label drugs than try and error, just give them the patient if he wants it. So from my perspective, it's better to test more and to treat less. Of course, if you correlate CTCs with cfDNA, you can do that. It's a different approach. cfDNA just goes for the mutations. The CTCs go for prognostic interpretations. So which is basically very alike of the cfDNA, but with the CTCs we also can do the drug sensitivity testing, and it brings another level of complexity. What I've tried a couple of times is combining all these tools in patients who were really sick, young, and were demanding a therapy after exhaustion of guideline therapies. So, okay, if I was lucky, I found in cfDNA some changes which I could use for them. I tried in the same blood round find CTCs, so I could perform functional testing on them. Of course, everything I find in blood is good for reasons of the heterogeneity. So in the blood, we have a mixture of all of the metastatic sites and all of the CTCs and cfDNA and from all the organs which may be of metastatic spread. And of course, if the patient says, I want a biopsy, I'm willing to let it perform through you. You can have a piece of my tumor and do 3D spheroid models. So in combining the methods, we can have improved predictive accuracy, and of course, we can make better decisions. This is quite a little bit new for me. We have a cooperation in Vienna with colleagues that perform stool microbiome testing and combine it with AI-based tool for bioinformatics and try to predict the efficacy and also the side effects of immune checkpoint inhibitors. So the test is not performed from the blood, not from the tumor tissue, it's from the stool of the patient. So it makes it even more convenient. And I'm just gathering now for the first year my experience with this. It's very exciting. So our patients, our metastatic patients, have a lot of lose. Yeah, they could lose their life because if the disease progresses, they are on the end of the line. So a lot of them say, okay, I want more information. I want to make better decisions for my maybe last try. Okay, let's go for tissue-based diagnostics because it gives me more information, but also brings the surgical risk, brings the risk of taking the biopsy, of bleeding, infection, maybe even you could miss the metastases by the biopsy and just biopsy normal tissues. So you have all the risk and maybe no gain. So the information which we have from the tissue in its amount is way more than we have from blood now, but the risk is high. With taking a blood, the risk is very, very low that we create some side effects. But from my perspective, as a clinician and as a lab physician, we don't gain that much information from the blood. So the challenges, of course, in the future are the oncology therapy is very cost intensive. So now we try to add high cost from diagnostics. But in every case, when I perform a very toxic, very expensive therapy and it doesn't work, it's way more costs than I would invest in a good diagnostics, even if it means combination of blood-based methods and tissue-based methods. If we really use AI for integration of all these findings, maybe we have a better predictability. Of course, future directions would be all integrate in together, like on the 3D model, where you can perform functional testing and omics. The expansion of AI, okay, again, go AI or die. Maybe we really need to train AIs on multiple centers on the same time and build big, robust AIs that would help us to integrate all this multi-omics data analysis. And of course, I mean, the future lies in the blood. When we find these rare events, when we find the DNA from the tumors, when we find CTCs, maybe exosomes, maybe other parts, microRNAs from the tumor, when we have methods sensitive enough to really be in the position of doing good predictions from blood, that will be the most convenient way for our patients. Thank you for your attention.
If anybody would like to raise a question, just put it in the chat window in the Zoom or in the other telecommunication sites we are streaming in, or just raise the hand and we can give you the live word as well. As long as I see, I don't see the questions yet coming up, so I have one, Martin, if you don't mind.
Please go ahead.
Okay, you touched upon this actually in the last slides, but what would be your optimal scenario in a case in oncology where we exhausted all the guideline-based treatments? So how would you approach a patient, for instance, for a lung cancer or a metastatic breast cancer, where we have limited options in normal medical oncology? So what kind of testing would you do, if you can do anything?
Yes, this is a situation that I had a couple of times in my life where the patient says, "Okay, now I'm very sick. I have a huge metastatic cancer somewhere which is hard to treat, and now doc, tell me outside the box. I can afford every methods on this planet. I can fly over the planet. I can buy everything. What we should do?" And my approach to this situation is like, okay, when the tumor is big, when there are a lot of metastases, I would go for tissue-based diagnostics and combine with some blood-based diagnostics. So maybe a very rational approach is to go for a tissue-based diagnostics first, do like 500 genes with NGS for finding maybe a druggable mutation. And if you end up with 20 mutations and 20 different medication, go for a functional testing afterwards. So just narrow the options after in the first step you find 5, 10, 20 medications which could work, and then you go with functional testing. So maybe my favorite functional testing is on CTCs, of course. It's very convenient to take then surgical biopsy again for 3D tumors. Maybe the patient's gonna say no, thank you. So a very rational approach would be start with the tissue and then go for functional diagnostics second in a very complex situation. When the situation is not that complex, maybe just the patient has a last line of guideline therapy and you just want to work in chemosensitization. So I go for functional testing where I test the chemotherapy or the targeted therapy in combination with some off-label drugs. So either way, in a metastatic situation, when the patient is in the shape of having another round of therapy, I would combine testing, and then even then, when I test a very good option, I would combine the targeted therapy or chemotherapy with some sort of immunotherapy. So I'm a strong believer in combinations, in good combination of debulking or some heavy chemotherapy, which is reducing the size of the tumor, and afterwards of immunostimulation, maybe with immune checkpoint inhibitors or even oncolytic viruses or dendritic cells. So I see advanced tumors more like a very complex situation where the patients have benefit from combinations of methods, even in diagnostic and even in therapies.
Very well, thank you so much. You know, we often see this case and the patient is in really good condition, but still we exhausted all the options. So there must be a step further and finding solution, and maybe even active therapy is available. So do you use, if you are using circulating tumor DNA, do you use your own testing method, or do you use also off-the-shelf services like Signatera or such cases from other companies like Foundation Medicine?
Yes, so I try really um, listen to my patients. If they want Gardan 360 or Signatera or Foundation One, I go ahead because I'm a therapist, so I try to have a lot of therapeutic freedom. Of course, if I can help my patients with my diagnostics, I do that because they are the tools that I use every day. And sometimes when you are very familiar with some tests, your interpretation of the test is better. So maybe it's easier to use something that you really know well than go every time with a different exotic diagnostic tool that it's hard to interpret for you for your tumor board. Yeah, so that's another thing we try to get together every week for a tumor board, speak about our results, speak about our patients. And I'm a true believer in network. So that's why I'm glad you invited me in this little conference. Even I'm sorry my camera is not working, but I hope my voice, you can hear it quite well.
Yes, thank you so much. And indeed, your voice and the quality makes up for it. So we are sorry not to see you, but hope to see you maybe in person one of the conferences.